Okay, good morning, everyone, and thank you very much, Stephen, for the opportunity. And I feel already very welcome to the group. So my name is Kibar Yared. I am a cardiologist by training. I trained at McGill University, where I finished my cardiac fellowship, and then moved on to Mass General, where I did a combined imaging fellowship in echocardiography and cardiac MRI. That's almost 10 years ago now. Since then, I've developed a keen interest in cardio-oncology after the American Society of Echo meeting in 2015, funny enough. And since then, I've worked very closely with one of the lead oncologists at our hospital system. And we together have built something that we're quite proud of, in fact, a very robust cardio-oncology program that now follows upwards of 800 patients at any given time. Our center is a quasi-academic center, so we do see fellows on a monthly basis, but it's not an academic center like at the downtown hospitals here in Toronto. And so our experience may slightly differ from others. So that's my intro. Thank you again for the invitation today. I'm quite honored to present. So our case today is a somewhat rare case of capecitabine-induced hypertriglyceridemia. And this case came to light perhaps only a couple of months ago when our oncologist called me with this problem. So I'm going to take you through the case, and then we'll do a topic review. It's not an extensive, complicated topic by all means. So I'm hoping to fill the time with a ton of discussion, but I'd also like to hear the ideas of the group as to if or how often they've seen this type of problem, how they've managed it, and whether it's changed their protocol of how they follow patients while on capecitabine. So our case begins with a 47-year-old female. Her cancer diagnosis is that of breast cancer. She was diagnosed in October of 2018. It was right-sided. It was a 10 by 10 centimeter, very palpable mass that was determined to be locally advanced, and I'll get to those details in a second. ERPR negative, HER2 negative. Her other medical history included hypertension and obesity. Importantly, she had no history of type diabetes mellitus. She had no history of dyslipidemia and no history of hypo or hyperthyroidism. Her medications simply consisted of amlodipine for her hypertension. She also took cod liver oil by her own direction and multivitamins on a daily basis. She denied smoking cigarettes, but did admit to smoking marijuana on a seemingly regular basis, and no alcohol intake whatsoever. I imagine you can stop me at any time for questions. I'm happy to do it that way, or if Stephen prefers, we leave all the questions to the end. Regardless, this is as much of a discussion as you want it to be, so please feel free. So initially, because of her ERPR negative status, the oncologist recommended strongly that she undergo a neoadjuvant chemotherapeutic regimen. And therefore, in October of 2018, she started treatment with adriamycin and cyclophosphamide in a dose-dense manner, followed by paclitaxel. She had no complications during those two regimens, and thereafter, in March 2019, underwent a right breast lumpectomy as well as a sentinel lymph node biopsy. As predicted by the oncologist, and this I gained from her clinical notes, as predicted by her, there was residual disease at the time of lumpectomy of about 1.4 centimeters. It was pathology graded it as a 3, but thankfully 0 out of 8 lymph nodes were positive. She then underwent radiation therapy with the long-term plan for her to start treatment with capecitabine based on results of one randomized trial at the time. So that was the plan. She underwent radiation therapy with no complications again. And so here is the timeline of her clinical case. So in 2019, way at the left of this, on July 15th, she started capecitabine, 2,500 milligrams BID. Ideally for her, she should have received 2,650 milligrams, but her oncologist decided to use this dose just to see what the tolerance was like. So clinically, she had absolutely no problems. She was warned about hand and foot syndrome. She was warned about diarrhea, but she seemed to tolerate it very well and was brought back into clinic on August 7th for the commencement of cycle 2. At the time blood work was drawn, the oncologist received a note from the lab that her blood sample was lipemic. However, she made a mental note of this and then continued with cycle 2. So cycle 2 went off without any problems as well, clinically that is, and was brought back on August 26th for cycle number 3. Again, the sample was noted to be lipemic, and at that point, the red flag went up and blood was sent off for a triglyceride level. And surprisingly, perhaps, the triglycerides levels were noted to be markedly elevated, and I have them written there at 17 millimoles per liter, or for those in other units, 1,504 milligrams per deciliter. Seeing this remarkable rise in triglycerides, the oncologist did the right thing at the time and held the capecitabine. She did a quick literature search at that time, realizing that hypertriglyceridemia is a reported side effect of capecitabine, albeit much less than 1% of the time. Regardless, as mentioned, the capecitabine was held, and then she was brought back into clinic a week later simply to check on the triglyceride level and then decide whether she should continue or not. Repeat triglycerides were measured on September 4th, exactly a week later, and they had almost normalized at 3.6 or 318 milligrams per deciliter. So then a conversation was had between the oncologist and her patient regarding the risks and benefits of moving forward. The risks were not minimal, seeing as though how high the triglyceride level had increased and the unignorable risk of acute pancreatitis. And so because of that, and because of the limited data surrounding the use of capecitabine in her case specifically, after talking to our patient, the oncologist decided to discontinue capecitabine altogether and then to follow her clinically thereafter with ongoing surveillance. Although the patient was quite disappointed, she agreed with her oncologist. The patient was brought back a month later simply to recheck the triglycerides and to have a mammogram. And thankfully, the mammogram was quite normal at the time, and her triglycerides had continued to trend downwards, measured at 2.6 millimoles per liter or 230 milligrams per deciliter. And so at that time, given that the mammogram was quite normal, it confirmed both their decision to continue with repeat surveillance. The patient was in a stressful period at the time. Her family was in the Bahamas during that hurricane, and so she was quite worried, and her thoughts were not really on her cancer at the time. 6 months later, she had a clinical assessment right in the middle of COVID pandemic, so this was a telephone assessment, but she seemed to be doing quite well, and this is on March 25th. And so they both decided to continue surveillance. So that's where we are currently in our case. And I've mapped out her laboratory results. Unfortunately, she doesn't have a full lipid panel each time. She only had a triglyceride level measured each time. So here's the trend that you see. Importantly, and I wanted to demonstrate that prior to treatment, way prior to treatment in December 2017, she did have an elevated triglyceride level at 3.02. Her total cholesterol was in the normal range. Her LDL was quite good, and HDL slightly depressed. She was on no statin therapy or no cholesterol medications at that time. So to go through a short topic review, capecitabine, as most of you are aware, is actually the prodrug to 5-fluorouracil. And capecitabine is mostly used in the treatment of adenocarcinoma of the colon or the GI tract, or refractory breast carcinoma, such as our patient. A quick review of the enzymatic activation of capecitabine, and this is important simply because it may play a role in the etiology of the hypertriglyceridemia. So capecitabine, as you see on the left of the diagram here, is absorbed through the intestines, as most drugs are, and then is readily metabolized not only in the liver, as you see in the middle, but also in the tumor cell itself. So capecitabine is broken down or metabolized into 5-DFCR, and then further metabolized into 5-deoxyfluorouracil. And this occurs with the same type of enzymes, both in the liver as well as in the tumor cell. And the enzymatic reaction between 5-deoxyfluorouracil into 5-fluorouracil occurs through the actions of thymidine phosphorylase. And I'm mentioning this because it becomes important, again, in the etiology of hypertriglyceridemia. At least we think it might be. So keep this diagram in mind. It will come back in a few slides. Capecitabine typically may result in common side effects, such as plantar palmar erythrodysesthesias, or hand and foot syndrome, and diarrhea. Those are the two more common ones. We do see patients presenting with nausea or stomatitis. Hypertriglyceridemia, if you really care to look through the FDA document on capecitabine, is really listed way down, many pages in. And Roche, who is the company that manufactures capecitabine, or Xeloda, notes that a grade 3 to 4 hypertriglyceridemia typically only occurs in 0.1 to 1% of patients. So it's barely mentioned deep into the document. These are the this is a typical grading system for the CTCAE. I wanted to highlight what the levels are for hypertriglyceridemia from grade 0 to grade 4. So if you remember, our patient had a triglyceride level of 3 at baseline, so she's already in the grade 1 zone even before treatment. However, as the triglyceride levels increase, the grading system, of course, increases as well. And given that her triglycerides had peaked at 17, she was quickly into the grade 4 category very early on in her treatment. And you'll see that this is slightly unusual and represents a very marked response or negative response to capecitabine.
So Kibar, you had mentioned that she didn't drink any alcohol, which certainly is an important consideration. But then the other thing is, had she ever had any diabetes?
No, she was not only not on treatment, but she had no past history documented of diabetes mellitus, type 1 or type 2. And she had no thyroid issues as well. So really, if she had any risk factors, it would be her obesity. That's about it. And who knows what other genetic conditions. I mean, she was 47 years old, and she started off with a triglyceride of 3 or 300 and something.
Right.
So in looking through the literature, there are several case reports, and that's really most of the literature is consistent of case reports. There are a couple of prospective and retrospective studies, which I'll share with you in a couple of slides. The more severe cases are listed here. 2 case reports of an associated acute pancreatitis, someone who newly developed diabetes, and then really the end of the spectrum is a patient who required aggressive lipid apheresis because of the marked hypertriglyceridemia. And these are all case reports that range from 2006, if you will, to 2012, 2014 at most. So this is not very, very recent literature, unfortunately.
In the cases of, this is Isaac Ray with calling from UT Memphis. In the cases when there was pancreatitis, was there also documented to be high triglycerides?
Absolutely, absolutely.
Okay.
I only wrote down, all of these cases had hypertriglyceridemia. Okay, they're reported initially as capecitabine-induced hypertriglyceridemia, meaning the triglyceride elevation occurred temporarily related to the commencement of capecitabine, but further complicating the hypertriglyceridemia was the presentation of acute pancreatitis. Does that answer your question?
Absolutely.
Great. The group of head by Seminara published in 2010 at the first noticing of a patient who developed hypertriglyceridemia during capecitabine therapy. And at that point, it triggered that group to follow prospectively a total of 38 patients who received capecitabine for a variety of cancers. And they wanted to try and understand what the incidence was of hypertriglyceridemia. So true, their sample size was quite low, but they found in 38 patients, 4 patients, or 10%, who demonstrated hypertriglyceridemia. And the triglyceride profiles of each patient is shown here in the diagram. So patient 1, 2, 3, and 4, in black, the black bar represents their pre-treatment triglyceride level, and the gray bars represent their post or middle treatment, if you will, triglyceride levels. And as you can see, 2 patients had marked elevation in triglycerides, whereas the latter 2, or the later 2, demonstrated only modest elevations. And so their concern at the time was that the incidence of hypertriglyceridemia in patients who are treated with capecitabine is quite elevated, even though their sample size was quite low. More interestingly, I really like this study. So this is the group headed by Michi, who published in British Journal of Cancer, again in 2010. So they sat down and prospectively studied the frequency and severity of CIH in routine clinical practice. So they took a total of 304 patients who were undergoing treatment for colorectal cancer with capecitabine. And they managed to screen almost 70% of them. And their incidence rate was noted to be much lower than the previous group at 3.7%. Clearly, they had 10 times higher sample size, which perhaps is much more generalizable than the small sample size in the previous group. And the 3.7% were actually found to have clinically significant hypertriglyceridemia that in fact necessitated lipid-lowering therapy. There were no cases of acute pancreatitis at the time, and they noted that the baseline triglyceride levels predicted the highest in-treatment triglyceride levels, which is very similar to our case presented earlier. So these are what their patients looked like. So there were 8 patients total out of the 300, out of the 70% of the 300 that got screened. And without dwelling too much on the minutiae of this graph, I simply want to highlight that pre-chemo, all their triglyceride levels were less than 5. Still, that's quite elevated. And then they peaked at the midpoint number 1, as you see there, and they slowly, gradually decreased. Now, it must be said that this decrease that you see here is the result of treatment and not the result of withholding of capecitabine. That's very important. But it did spur the idea that perhaps there should be some type of routine surveillance of triglyceride levels during treatment with capecitabine, and furthermore, a protocolized treatment of the triglyceride level should it be noted to be elevated. And I'm sharing this with you now, but it's much more relevant towards the end of the presentation when we talk about recommendation for surveillance and treatment. But it originated with this group, where, as you see here, on the left-hand side is the level of triglyceride, and on the right-hand side, what action was taken. And this was true of every patient that was noted to have high triglycerides. The family physician was immediately and directly involved in whatever investigation and or management was required. But as soon as the triglyceride level inched above 5 millimoles per liter, anywhere between 5 and 10, these patients were commenced on oral fenofibrate at a dose of 267 milligrams daily. Concomitant with this was a calculation of cardiovascular disease risk. Again, involvement of the family physician for longitudinal monitoring of the hypertriglyceridemia. If the chemotherapy with capecitabine were discontinued or held, triglycerides continued to be monitored until it was sure that capecitabine was either completed, the treatment with capecitabine was either completed, or that it was discontinued altogether. And nicely, if you will, after the triglyceride levels had gone back to baseline or normalized, the fenofibrate was discontinued. So it was clearly a protocol designed to treat the hypertriglyceridemia in the acute phase in order to help with continuation of potentially life-saving chemotherapy with capecitabine. Another group led by Barcela and their group looked retrospectively this time in a population of completely unselected patients, but treated in only one center. And their objective, was to look for possible risk factors. So which kind of patients, what type of patients do end up getting hypertriglyceridemia? And their retrospective study ranged over the course of 18 months or so, perhaps a bit longer, between May 2009 and December 2010. They identified 289 patients at the time. However, only 102 met the inclusion criteria, which was basically, do they have enough triglyceride measurements to garner any conclusions? So out of the sample size of 102, they made sure that all of them had a baseline triglyceride level and their peak triglyceride level during treatment. So this is what the demographics looked like. If you look on table 1 on the left, you'll see that the study group, which consisted of 102 patients, is the middle column. And then all patients with a grade 2 or more CIH, displayed as absolute number and then percentage of the study group in parentheses. So I'll call your attention to the pertinent positives here. Most of the patients were between the age of 50 and 70. Most of the patients were female. And then there was a majority of patients that received capecitabine for upper gastrointestinal tumors or colorectal cancers, with breast cancer making up the rest. Capecitabine was used as a single agent, just as likely as it was combined with oxaliplatin and or bevacizumab. Now, importantly is the incidence of CIH in those who are diabetics. And as you can see here, although the numbers are small, the percentage of the study group who had diabetes is higher in the CIH group than in the non-diabetic groups. So clearly there is a signal indicating a higher incidence of CIH in those with type 2 diabetes or with diabetes. There's no stipulation here whether it was type 2 or type 1. The same goes, well, no, sorry, not the same goes in the hypertensive population. And so although the study group more had hypertension, there was no statistical significant difference between those who developed CIH and had hypertension and those who developed CIH and did not have hypertension, even though it trended the opposite direction. There were more people who had ischemic heart disease in the CIH group, and there were more people in the CIH group who had pre-existing dyslipidemia. Again, there were more people in the CIH group who had a BMI of more than 35, defined as obese. On the right-hand side are the group of patients who had triglyceridemia, the majority of these patients occurring with triglyceridemia rated as grade 1, as in less than 300 milligrams per deciliter, and then the 20 patients of interest of having CIH grade 2 or more displayed to the right of that. So again, CIH grade 1 to 2 was much, much more common, as would be guessed, than grades 3 or 4. Now, it's easy to focus on the chemotherapeutic regimen being the sole etiology behind the hypertriglyceridemia. However, in educating the patient or in intervening, one must not forget the more common causes of hypertriglyceridemia, and especially those that we see in the general population, those not, did I just say comma? I'm so used to dictating, I'm sorry. And those who are not receiving chemotherapy. So let's not forget those who have rapid changes in diet. They may be eating worse during chemotherapy because that's what helps with their nausea, for example. They may have increases in weight. And those who start off treatment with significant alcohol consumption or who have uncontrolled diabetes. One must not forget that the thyroid metabolism can certainly lead to altered metabolism of triglycerides and leading to increased triglyceride levels. So all of these on the left-hand side can certainly be acted upon with lifestyle modification and strict education to help not only reduce their baseline levels, but in doing so, you can hopefully reduce the risk of incidence of CIH while receiving chemotherapy. There are medications such as beta blockers and glucocorticoids and antihypertensive medication like thiazides, which may certainly increase the triglyceride levels. And those should not be forgotten, especially if there are alternative options that can be used that do not affect the triglyceride level. So keep those in mind when trying to treat the triglycerides that develop. What about other chemotherapeutic agents? Well, this is not a chemotherapeutic agent, but tamoxifen has certainly been shown to manifest in hypertriglyceridemia. And this is because it reduces the action of hepatic triglyceride lipase. And I'm going to go through a schematic in discussing the etiology of hypertriglyceridemia, at least with capecitabine, but clearly the lipases, be it lipoprotein lipase or hepatic triglyceride lipase, have an integral role in cholesterol breakdown and metabolism. And any interference in their mechanistic activity can certainly lead to hypertriglyceridemia. Lipid disorders have also been described in therapies with mTOR inhibitors, with immunosuppressant drugs, interferon, as well as asparaginase. But our focus today is on capecitabine-induced hypertriglyceridemia. And so, as I've shown you in the several case reports presented, but also at least 2 others, there is clearly a message that has come across wherein patients who have a history of dyslipidemia, obesity, hypertension, or type 2 diabetes mellitus have an increased risk of developing CIH during their therapy. And so close attention needs to be paid to these patients, either with early lifestyle modification, early intervention, or close monitoring of triglyceride levels during treatment. So I'd like to spend a few slides discussing how capecitabine is related to hypertriglyceridemia. Initially, the thought was whether it's dose dependent. Typically, patients receive, and I may be wrong here, but what I've seen is anywhere between 800 and 900 milligrams per meter squared. And so our patient received 2,500 milligrams BID, which is lower than what she was supposed to get. But across the range of capecitabine doses, we have seen a demonstration of hypertriglyceridemia. So clearly there is no strict dose dependency there whatsoever. And as I've shown you in the previous case report, whether patients receive it as monotherapy or as part of a combination regimen, there is an incidence of CIH that is almost equal across both groups. So that's not it. We've also noticed that typically CIH develops later on in the stage of treatment. So the reports that I've seen have demonstrated peak triglyceride levels anywhere after the 2nd cycle, well into the 8th cycle. Our patient is slightly different. She developed it after cycle 1, in fact, with that lipemic sample, although the triglycerides were not measured at that time. Regardless, before the 3rd cycle, she had marked hypertriglyceridemia. But generally, what I've seen in the literature is that the peak occurs much later on. And so it's reasonable to assume that the enzymes required to metabolize triglycerides may have changed in expression, perhaps as a result of the capecitabine itself or other indirect causes. And so the time required to have that fits with the time seen with the development of hypertriglyceridemia, as in more than cycle 2 or later than cycle 2. So the hypotheses present out there in the literature include that perhaps the hypertriglyceridemia is induced by the capecitabine itself or the generated metabolites that I've shown you in that schematic early on before the formation of 5-FU. Because we know that the use of 5-FU does not result in hypertriglyceridemia. So clearly, something above or upstream from the formation of 5-FU is the causative agent. We also think that it may be due to enzymatic interference by the capecitabine itself of the lipid metabolism. And this is what I was mentioning early with lipoprotein or hepatic triglyceride lipases. And their activities may certainly be diminished as a result of the capecitabine use, resulting in hypertriglyceridemia. So this is back to medical school, at least for me, with respect to cholesterol metabolism. So as you can see, dietary fat gets ingested in the small intestine at the bottom of this diagram, and chylomicrons are extracted from the dietary fat. Chylomicrons are mostly triglycerides, as you see there in blue. And then the enzyme lipoprotein lipase is responsible to break down the chylomicron into remnants and free fatty acids that are then taken up by the liver and then further metabolized by hepatic lipase. Lipoprotein lipase is also involved in breakdown of very low density particles into intermediate density and then into low density. So the lipoprotein lipase molecule or enzyme is involved right along the cascade of breakdown of cholesterol, and any interference with that can result in a marked accumulation of any of these remnants of chylomicron, thereby resulting in an increase in triglyceride levels. Okay. So we also think, not we, but Dr. Javel in the British Journal of Cancer, who postulated that perhaps those with genetic defects in the lipoprotein lipase enzyme, those with an excess of apolipoprotein C3, which is an LPL inhibitor, and conversely, those with a deficiency in apolipoprotein C2, which is in fact an LPL activator, So anybody with genetic defects in these three types of enzymes may certainly have a strong predisposition towards developing hypertriglyceridemia while receiving capecitabine. Not to mention that these patients are likely at high risk of developing hypertriglyceridemia even without capecitabine. Definitely there is a relationship. It seems to be coming out now. There is a relationship between the activity and presence of these enzymes, or the defects in these enzymes, and the development of hypertriglyceridemia in patients who receive capecitabine. Now back to this schematic. So in the tumor cell, as I mentioned to you, capecitabine or another metabolite called tegafor, these are two chemotherapeutic agents that are used routinely. Both are metabolized by thymidine phosphorylase into 5-fluorouracil. So both of these are precursors of 5-fluorouracil, and both, like I mentioned, are used routinely in cancer care. And what they both have in common is this enzyme that metabolizes them into 5-fluorouracil. As mentioned, we do know that 5-FU does not result in the presence of hypertriglyceridemia. We have seen several case reports of capecitabine-induced hypertriglyceridemia, and we also have seen tegafor-induced hypertriglyceridemia. And therefore, seemingly, the precursors of 5-FU are resulting in hypertriglyceridemia, whereas 5-FU is not. And it stands to reason that perhaps the one common aspect of all of this is the thymidine phosphorylase. And that's all we know for now, that we're implicating something with thymidine phosphorylase to cause the hypertriglyceridemia. Is it an action of this enzyme on lipoprotein lipase? Is it an action of the capecitabine itself on this enzyme? It's really unclear at this time, but the theory exists that something wrong with the thymidine phosphorylase is resulting in this hypertriglyceridemia. Or, sorry, is resulting in the elevated levels, perhaps, of the precursors that indirectly result in hypertriglyceridemia. That flow, implication cascade, if you will, is not clear at all just yet. So as I mentioned, I rifled through the numerous pages of the FDA document highlighting the use and side effects of capecitabine. And as is very common in most chemotherapeutic agents, when patients suffer a grade 2, grade 3, or grade 4 adverse event, the recommendations are as follows. If the patient were to suffer a grade 2 adverse event, then the recommendation is that the capecitabine needs to be held until the resolution of the adverse event down to a grade 0 to 1, or down to baseline levels, hopefully. And then with grade 2, you can resume the capecitabine at 100% of the dose. However, if this is the second or third occurrence, then the dose reduction is much more marked when resuming the medication. With grade 3 adverse event, again, the capecitabine is held, but the dose reduction is more marked. And then, of course, with a grade 4, if you're still brave enough to restart the chemotherapy, then the resumption is at 50% of the dose. And again, if the occurrence is the second or the third, the dose reduction is more marked. One would say that if there is a second occurrence of a grade 4 adverse event, that perhaps that chemotherapeutic agent should cease to be used and perhaps an alternative found. I mean, what I see our role as cardio-oncologists is partly is to try and maintain these patients on potentially life-saving chemotherapy. And our role is to help intervene with these patients without or with as little interruption of therapy as possible. And therefore, should they suffer a grade 4 adverse event, strict or robust intervention in lowering their hypertriglyceridemia may certainly result in their resumption of capecitabine if it is their only option at the time. And sadly enough, when I discussed my case with our oncologist to help the patient go back on capecitabine, it was decided at the time, both by oncologist and patient, to stop therapy simply because they're basing her treatment based on one single trial. And she wasn't convinced enough that the capecitabine would result in a mortality benefit, let alone a morbidity benefit. And so she was comfortable in stopping the capecitabine at that time. Obviously, I'm not an oncologist and I don't know the intricacies of how good capecitabine is for that specific patient, so I went along with it. But at that time, I certainly did encourage the use of a statin or a fibrate or something. I even, reached out to her when I was putting this presentation together to see if perhaps we can get her back on therapy. But at this point, it's been more than 6 months since her adjuvant chemotherapy, and therefore unlikely to be of significant benefit, at least according to her. Nevertheless, she's on routine surveillance now, so hopefully she'll continue to do well. I tried high and low to look through the clinical guidelines. I looked through ASCO. I thought cardiology had a ton of guidelines. Certainly cancer therapy has a significant number of guidelines to try and find whether the guidelines have changed with respect to monitoring of triglyceride levels during therapy. And currently, it is my understanding that they are not routinely recommended. However, numerous case reports and that one prospective and that one retrospective study strongly recommend the monitoring of lipids during such therapy. And simply because although the risk of a grade 3 or 4 adverse event is still quite low, the risk of a grade 2 event is not that low. And certainly an elevation in triglyceride levels up to a grade 2 level still may confer a risk for further metabolic complications, the most dangerous of which is an acute pancreatitis. And therefore, the anecdotal recommendations are that the high-risk patients at least have a lipid profile measured at baseline, at cycles 2 to 4, where we think that the hypertriglyceridemia shows up, and then before the end of therapy. And when I mention high-risk patients, what's clear to us are the patients who have diabetes, who have dyslipidemia at baseline, who have obesity, and perhaps who are hypertensive. Those are the big 4 that have demonstrated marked elevation in triglycerides during therapy. So what can we do for these patients? Definitely, as I've mentioned a few slides ago, focus on the known causes of hypertriglyceridemia, irrespective of the chemotherapeutic agent. These are perhaps much easier to intervene upon, educate the patient in hopes of minimizing the elevation in triglycerides. But then should the patient require lipid-lowering therapy, the first-line agent to lower triglycerides is a fibrate. And I showed you the protocol brought on by Michi et al., wherein they started fenofibrate at a dose of 267 milligrams as soon as the triglycerides crossed the level of 5. But there is strong evidence that statins reduce triglycerides very well. There is a role for omega-3 fatty acids, perhaps more so in combination with a fibrate or a statin, but not by itself. Niacin has also been shown to lower triglycerides. However, it is usually poorly tolerated because of the significant flushing that these patients suffer. PCSK9 inhibitors can also reduce triglycerides by up to 37%. I'm sorry, I didn't mention it here. But also new on the block is ethyl eicosapentaenoic acid, or Vascepa, and that's the new kid on the block to lower hypertriglyceridemia. At least in Canada, it's not. It's definitely available, but it's not covered by our government health plan, and so it's still reserved for those either with private plans or those who are willing to pay for it. Again, this specific drug has not been tested out in this specific patient population, but certainly a consideration. So to conclude and hopefully allow, there's ample time for, I hope, ample time for a discussion. CIH, given the numerous case reports that are out there, only probably half of which I've presented today, is certainly an increasingly recognized treatment-related adverse event of capecitabine. If intervened upon early on, we can certainly abrogate the potentially significant acute and chronic metabolic complications, namely acute pancreatitis, but we can't forget about the development of coronary artery disease or peripheral vascular disease that can be seen with hypertriglyceridemia. Fortunately, of course, most cases of CIH are asymptomatic, and that behooves us to look carefully and not wait for the acute abdominal pain that goes with the acute pancreatitis to present to our clinics. And so, thankfully, by either withholding the medication, the chemotherapy for a short period of time, or starting lipid-lowering therapy concomitantly with maintenance of chemotherapy, we can reduce these triglyceride levels to subclinical levels or to levels that are much less dangerous for the patient. And then, of course, once the triglyceride levels have normalized, then the chemotherapy can be resumed, hopefully safely. And then, of course, we see that triglyceride levels remain normal or go back to baseline for a sustained period of time after the chemotherapeutic regimen has been completed. And therefore, long-term therapy with fibrates or statin may not necessarily be required. So clearly, it appears that this is a short-term problem, as long as the chemotherapy itself is limited to, of course, a short term. But again, that depends on what the cancer is and what the opinion is of the oncologist. So with that, I thank you very much for your time, and I'm happy to take questions or discussion. I do want to start off the discussion, if that's okay, with the 40 or so people who are here. I'd like to know or hear from your centers and what you do with respect to monitoring of lipids, if at all, and whether you try and keep these patients on therapy while managing their triglycerides by other means. Thanks again.
Great job, Kibar. I think we could start with your question, but I would probably add a couple of other questions to consider, where to go as far as discussing this issue. So for example, if you look at all the breast cancer trials out there, so in whatever drug, whether it be trastuzumab or pertuzumab or anthracyclines or any of them, they do not monitor lipid panels. They don't do it at baseline, and they don't do it during study. So for example, there was a publication in JCO in February this year, looking at capecitabine in combination with other drugs for triple-negative breast cancer. And it was a big trial. Total number of patients is about 600. And they showed a benefit from using capecitabine in that particular cancer.
Okay.
So, but there is no measurement of lipid panel at baseline or during follow-up at all in that entire study. And as far as I can tell, they weren't ever measured. And in terms of other major trials, that's the same thing. There is no ascertainment of a lipid panel in a cancer treatment trial. That's just, they just don't do that. They do chemistry panel and they do CBC and whatever else they're looking at, but they do the basics, but they don't do that. And so I think it's quite possible that although this is a rare, what appears to be a rare side effect, it would be serious. And I don't think that there's any way of monitoring for that problem in the existing cancer treatment trials. So that's a big problem, that this is a hole that is not measured. It's not looked at. And then the second is that I would be very cautious about, you know, if a person had the kind of idiosyncratic response that you had in your case to capecitabine, that I would be very hesitant to push for that drug unless they said that that was the only drug that would be effective. Now that's an oncology question that I don't know the answer to, but
right. And that's why I didn't, you know, I offered, but I didn't push, obviously, because she is much more versed in the advantages or disadvantages of continuing the drug, and seeing how quickly she discontinued it. The fear of hypertriglyceridemia overwhelmed the perhaps perceived benefit of continuing the capecitabine, which suggests to me that the impetus to continue the capecitabine in this patient specifically wasn't as strong.
yeah, I think it might be becoming stronger over time, because they're like this other paper that I was referring to is showing that capecitabine may be helpful, may be an additive drug. So I think that chances are we're going to see this more often, but we're certainly not going to see it if we don't measure a lipid panel.
And thankfully, or perhaps fortuitously, right, the sample was lipemic enough to flag. In those patients with triglycerides of 300 to 500, you may not see such a lipemic sample, and clearly the triglyceridemia will go undetected.
Yeah, so I think that this is probably an idiosyncratic reaction for this patient. And as you pointed out in your other slides, you know, there's some mechanism down there that perhaps capecitabine affects that metabolism in some unique way. And I personally would be very cautious about using that medication in this patient.
Right.
But on the other hand, I also think that we really have no idea how often this occurs because we don't measure lipid panels. And
yeah, so I agree with Dan. I think it's probably more common than you think, and that and there's a myth with the fluoropyrimidines about reducing the dose to reduce cardiac side effects, and I don't think that it's dose related. I love that Dan said that it's an idiosyncratic reaction, because I think that there is hypersensitivity in some people, and that's sort of the mechanism. It's another plea that anybody who is getting fluoropyrimidine, especially if they have any cardiac risk factors whatsoever, should be seen by us before instituting therapy.
And absolutely get a lipid panel, especially.
Exactly. What's the harm in just adding a lipid panel to the routine blood work? I mean, it's a question of putting in the protocol. That's all it is, I would imagine, at least at our institution.
I mean, that's what you would think, but you know, search your clinic referrals for the past 2 years. Look at all the breast cancer patients that were sent to you, and just tabulate how many times did they do a lipid panel before they started chemotherapy.
Never.
I would hazard a guess that it will be under 5%.
It's like zero. I always joke that they don't get lipid panels and we don't get flow cytometry.
Yeah, but
And
you
the
know,
other reason to
the other thing that's really unusual about this is that I couldn't, while you were talking, I couldn't find a single case of 5FU reported hypertriglyceridemia.
Right.
So it seems to be unique to capecitabine and not 5FU. Now,
That's right.
Joe, do you have a comment there?
Yeah, I've never seen it.
I think in general, it's a good idea to get lipids because of the coronary issues that they often get, the coronary vasospasm. I think it's a very good idea to get lipids and always ask for it. So this is obviously probably even more important than for capecitabine than just in anybody getting 5FU to get their cardiac risk. So in case they do get vasospasm, it's not going to lead to a major infarction, hopefully. There's no data on that, of course.
No.
No, and I think that the harm in continuing therapy in somebody who had this kind of reaction, not only is pancreatitis a problem, which anybody who's had pancreatitis doesn't want to have it again, but there were a few case reports of progressive fatty liver, and I think that it may take a while for that to become a real issue, but I think that progressive fatty liver is going to lead to cirrhosis and potentially liver failure. So I would be very careful about it in your patient anyway, but I don't know how often.
If I could speak to some oncology, I would think that use of capecitabine as it was in this patient, after the previous chemotherapeutic regimen and surgery, is a different situation than using capecitabine primarily for colorectal cancer, for example, right? Because using it for breast cancer that's recurred or that's incompletely treated with other agents is a different prognosis, it's a different success rate than those used for in a primary setting for colorectal cancer. And so in the colorectal population, it becomes that much more important to maintain the capecitabine as much as we can, right? And so I understand your fear of continuing therapy when they get such high triglycerides. But if they're monitored more closely with intense lipid lowering therapy and they continue, they may do much better than we like. Not that we like, sorry. They much than we thought by continuing the capecitabine, because it's much more important for their colorectal cancer.
I think your point was well taken, but I would argue, do you really need to use oral drug in that case? I'd probably say use 5FU. And
yeah, sure.
But in the case of breast cancer, I do think that capecitabine is being used more commonly, and partly because of the report that I told you about just a month or two ago. Breast cancer being so common, and the breast oncologists are always looking to adding a new drug or whatever. I mean, there's constantly new therapies that they're putting into the mix. So right. I think that chances are you're going to see this more frequently going forward.
Which then belies the importance of being on top of potential side effects as much as possible.
No doubt.
Yeah. Is anyone going to change their protocols at their center? Is there anyone going to talk to the oncologist a bit more seriously about measuring lipids? Has this swayed them in any way?
For me, I've already been bugging them incessantly, so I'll just be a little more vociferous about it.
Lure me to that class with promises, donuts, loose women. Sorry. I honestly thought they'd be done.
I didn't hear that.
Yeah, I didn't either.
Okay.
All right. Well, we really appreciate your presentation. Thank you so much. And really great case, great discussion. We look forward to hearing more about what happens with you in the future, for sure.
I thank you again. It was really an honor and a pleasure, and always fun to discuss things with you guys.
Great.
Yeah,
Thank you,
great.
Peter, so much.
All right,
Thanks,
Steve,
everybody.
we're on tap for next week, same time?
Yes,
Yeah.
next week, same time, there'll be a COVID-related discussion, COVID-related presentation. So hope you can join us then.
Great.
Great. Thanks a
Stay
lot.
safe,
all.
everyone.
See you, everybody.
Thanks, Kibar.
Thank you.
Thank you.